The traditional perpendicular intramuscular injection operates on a simple premise. A needle enters the skin at a 90-degree angle to deliver medication directly into deep tissue. The biomechanical flaw of this method is the path it leaves behind. It creates a single, continuous, linear channel through the epidermis, subcutaneous fat, and the muscle fascia. Looking at this animated cross-section, you can see how the internal hydrostatic pressure from the muscle tissue naturally forces the injected fluid back up this open linear channel. This retrograde movement, known as tracking, reduces the total dosage absorbed by the muscle. Worse, it exposes the sensitive subcutaneous layers to severe tissue staining and localized sterile abscesses. Certain pharmacological agents mandate an alternative approach. Highly irritating, viscous, or oily solutions, such as iron dextran, cannot safely remain in the subcutaneous layers. Clinical efficacy depends on a mechanical seal that locks the solution within its intended anatomical compartment. Creating a perfect seal begins before the needle touches the patient, during the medication drawing phase. When you extract these harsh medications from a vial, the primary drawing needle inevitably becomes coated with trace amounts of the chemical irritant on its exterior shaft. To prevent tracking, you detach the contaminated drawing needle and lock a pristine, sterile needle onto the syringe before injection. Selecting the correct gauge is also essential. Viscous or oily medications require wider 18 to 21 gauge needles to allow a steady flow without excessive plunger pressure. Following CDC standards, you must cleanse the injection site with alcohol and allow it to dry completely before insertion. Injecting through wet alcohol, or failing to swap the needle, inadvertently introduces chemical irritants directly into the precise tissue layers the Z-track method is specifically designed to protect. This technical diagram shows the ventrogluteal site, the absolute standard for Z-track administration. Its thick gluteus medius muscle and thin subcutaneous fat lie safely distant from major vascular pathways. To map the landmarks, place your palm over the greater trochanter, pointing your thumb toward the groin. Extend your index finger toward the anterior superior iliac spine, and middle finger toward the iliac crest, creating a V-shaped safe zone. Selecting a site with this optimal geometric landscape and depth provides the biological prerequisite for creating an effective mechanical seal. In a resting physiological state, the layers of the injection site, the epidermis, dermis, subcutaneous fat, and deep muscle, exist in a continuous stacked vertical plane. The Z-track technique exploits the natural sliding properties of the subcutaneous fascia to disrupt this alignment. Using the non-dominant hand to apply firm pressure pulls the skin and fat laterally, moving them out of alignment with the deep muscle. Conversely, the common clinical error of pinching the skin incorrectly pulls the muscle upward, reducing available needle depth. The tissue must be held completely taut in this laterally displaced position for the entirety of the injection process. This displacement anchors the deep muscle as a fixed anatomical landmark, while the surface layers act as a sliding gate. Creating this intentional anatomical misalignment is the primary engine that will eventually trap the medication. While maintaining strict lateral tension, the dominant hand inserts the needle at an exact 90-degree angle. The needle path pierces through the temporarily displaced superficial layers directly into the targeted anchored muscle fiber. Once inserted, clinical guidelines mandate a slow injection rate of exactly 1 milliliter of fluid dispensed every 10 seconds. The viscous fluid diffuses smoothly into deep, fibrous red muscle tissue without causing rapid expansion or sudden cellular swelling. This deliberate fluid dynamic prevents sudden tissue distension and minimizes the internal hydrostatic back pressure that drives retrograde leakage. Managing fluid pressure through strict speed control prevents the medication from seeking an upward escape route before the anatomical seal is finalized. After the plunger is fully depressed, there is an immediate stabilization period. The needle must remain stationary in the muscle for exactly 10 seconds. This pause serves a biological purpose. It allows the initial concentrated bolus to begin dispersing into the surrounding muscle fibers, rapidly reducing localized pressure at the needle tip. The withdrawal phase requires highly synchronized movement, removing the needle at the exact 90-degree angle while simultaneously releasing the displaced tissue from the non-dominant hand. Watch this cross-section animation to observe the bounce-back phenomenon. as the elastic subcutaneous fascia instantly snaps the epidermis and fat back to their resting physiological alignment, the straight needle track fractures into a disconnected, staggered zigzag pattern. This rapid tissue movement forcefully pulls the various layers of the needle track out of alignment with one another, visually blocking the pool of medication. This process is known as guillotining the needle channel, effectively obliterating the vertical pathway to the surface. The resulting zigzag geometry permanently severs the track and traps the drug where it belongs. Post-procedural care for a Z-track injection requires minimal interference. Only gentle pressure with a dry gauze pad is acceptable, and only for minor surface bleeding. A frequent, deeply ingrained, and dangerous clinical mistake is vigorously massaging the injection site after the needle is removed. While massage may stimulate blood flow for standard intramuscular injections, it is strictly contraindicated in Z-track administration. This animated diagram illustrates the destructive physics of this error. External massage generates downward pressure, causing the staggered zigzag track to momentarily open, forcing the trapped fluid back up into the subcutaneous fat. This single error completely undoes the biomechanical advantage, re-exposing the patient to tissue necrosis and permanent cosmetic defects. True clinical excellence in the Z-track method requires strict adherence to these biomechanical realities, from the first needle swap to the final hands-off approach, to guarantee pharmacological efficacy and patient safety.